wonderful reminder, not only of the wonderful work that's taking place, but where we're headed going forward. We have some wonderful services that are taking place. I'd love to comment on the things in the chat, but it's time for us to get over to the regular crisis jam. So let's do our countdown.
From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
Hello, everyone, and welcome to Season 6, Episode 248 of the Crisis Jam. I'm Dr. Brian Sims. I'm Senior Medical Advisor with the NASPIT organization, and I want to say to everyone, Happy New Year. We're coming into 2026 in such a wonderful way, and as you can see from your slide here, we are going to be going today into the next debate number 10. Should medical clearance be required for admission to crisis facilities? And we have with us Jonathan Thomas and Kevin Curtis, who later will go into the debate. And we're happy to report that Monica Johnson's going to be the moderator for this debate. So it's an exciting episode and really looking forward to the information that we get. Thank you all for joining us. And as we move in, just an understanding that crisisjam.com is the place to be. Go to that site. We're talking about shaping this future and really tuning in, logging on, and being able to join the movement. You can also see within some of the things that have happened in prior jams and our lead stories, and also some forward things that would be coming that will give us information about what's going on ahead in the jam schedule. Now, if we move on. Also, a reminder about our YouTube uplinks. We're seeing that many of you are liking it and subscribing to it. Please do continue to join, and remember that you can join to the Crisis Jam through the YouTube as well. Okay. Now, what we want to do is announce about this. You can see from this, global leadership has been wonderful with the Crisis Now. And we are happy to report that Crisis Now 4 is on its way. Registration is already taking place. And if you are in it, you will be able to see that in Crisis Now 4 that is scheduled for Washington, D.C., there are going to be a number of factors that are taking place. We're going to have critical debates within, fireside chats, lived experience talks, special events, and virtual tours of next generation things. So it's going to be such a wonderful, wonderful way to kind of come into 2026 with what's happening and how you can make a difference in doing those things. So next slide, please. We want to go into a pre-survey debate with each of you and ask you to place your answers into the chat box, if you will. And it is medical clearance should always be required for admission to a crisis facility. You see the responses before you, and we ask you to then place it. We will give you a response later at a later time, but we ask you to either answer the pre-survey, or if you would like to drop it into the chat box, please do so. Now we want to get to our breaking news, because there's a couple of things that we wanted to just bring to your attention as far as the breaking news for today. Okay, the first has to do with CMS approving rural health awards for all 50 states. Many of you are already aware of this. This is an article that lets you know that CMS will distribute upwards of $50 billion across 50 states in 5 years, and that these awards will generally be around $200 million. So it is already in operation, just give you some information to work with. The next breaking news has to do with the National Survey of Mobile Crisis Co-Responder and Alternative Response Programs, and it offers you the opportunity to scan for more information and to participate in this particular survey. So you can start voting in that regard. Now, I would like to get to our hot seat Q&A. And in this hot seat, we have today with us the grandfather of 988, Dr. Richard McKeon. And Dr. McKeon, we want to thank you ahead of time for joining us on this Q&A. So Dr. McKeon, if you are there, you'll come on board. Okay. Not seeing Dr. McKeon just yet. So what I'll do is throw this out as an audience participation.
I'm here.
Oh, there you are. Thank you. Hi, Dr. McKeon.
Hi there.
To hear your voice. We are involved in the Q&A, and you are the lone person for today. So we thank you for joining us, and we thank you for participating again in this Crisis Jam swag. And it's a reminder to everyone that those who participate are able to get a Crisis Jam swag, t-shirt, or whatever through our Crisis Jam show. So Dr. McKeon, for you, sir, in Crisis Jam episode number 36, over 200 episodes ago, Dr. Chris Carson described the first step in beginning care in a crisis facility. And the question is, what was it? Was it A, prior medical clearance in a hospital ED? Was it B, submission of referral information by fax or email? Was it C, BAC report if intoxicated? Or was it D, ring the doorbell? And we'll place this all out for the audience to participate as well. And Dr. McKeon, I will turn it over because I've not found a person to yet fool you. So I'm I'm not going to be the for sure.
Yeah, so this is what I would say. So the I know that Dr. Chris Carson was an innovator in doing this kind of work, and that he and so that I think that this question is focusing on what is ideal under the kind of models that Dr. Carson initiated, and really in many ways has become the basis for crisis stabilization units with things like police drop-off all across the country. So here's what I would say. Prior medical clearance in a hospital ED is precisely what is not required. So there have been numerous discussions around this. So I don't think it would be about prior medical clearance. Submission of referral information by fax. Well, particularly, fax machines are not really current technology. That would also be a bit of a delay and a barrier to getting needed care. So I think it would be not in accord with the philosophy in crisis facilities. A BAC report if intoxicated. Well, again, that's one thing that, is often required in many places, but it requires swinging through the emergency department or elsewhere to do it. So I think that the idea here is to be able to get in as quickly as possible. So I'm going to go with D, ring the doorbell.
Wow. And Dr. McKeon, I have to say, just listening to your rationale and your reasoning is such a learning experience. You want to just sit back and absorb as much as you can. But I will say that apparently it has quite a bit of significance to the audience, because the audience poll has roughly 72% agreeing with you on this. So if we go to the correct answer, it is, it is ring the doorbell. And
All right.
Carson had described medical clearance as a shield for the system and a barrier to care. So Dr. McKeon, as always, thank you for that. You have been absolutely the best in terms of reading through these questions and giving them a lot of thought before responding. So we really thank you for that. And we'll ask you for a second to hold on, because we're going to come back with the over-under with you. But I want to
Okay.
move to this next slide on traditional approach. And I'm going to ask at this time if Chris Santasiero would come on board and join us.
Brian, could you hear me?
Yes, got you now, Chris. How are you, sir?
Great.
Wonderful,
Happy New Year.
wonderful. Just thought if you give a quick comment on this particular slide in terms of traditional approach and next generation approach, sir.
Sure. And, this is I'm Chris Santacero. For the folks that don't know me, I'm the Vice President of Government Affairs at Connections, and I have the great pleasure of helping scale the model that Dr. Carson helped found in new states across the country and partnering with state and local governments. And this is the number one question we get asked. And it's proven to be effective. And I think a lot of the work we did with SAMHSA, identifying the tiers and guidelines, and then the recent best practices state health official CMS letter around all this that really kind of shows this model as the emergency capable model that it is and how it functions on par with the medical emergency system as an alternative to the hospital emergency departments, an inpatient psych offering 24/7, no barrier emergency psychiatric access to treatment. So it's very effective. And in Connections, we support and advocate for all parts of the continuum around the safe place for help, including mobile crisis and in par with partnership with first responders, mobile crisis law enforcement, and first responders. But the reality is, like, there's a continuum of care that needs to function in a lot of communities on par. So looking forward to the debate today and hearing more about all aspects of, because the continuum is what matters most in all communities, having not only that emergency capable function that Connections provides and other great providers like RI, but then also having a continuum so that people can be discharged safely back to community-based settings. So thank you.
Well, thank you, Chris, and thank you for emphasizing continuum.
The time has come for this.
Thanks again, Chris. We're going to move to our over and under at this point. And Dr. McKeon, this over and under, we're going to ask you for the percentage, and we'll check with the audience through the chat box to determine their responses, whether they feel it's over or under. So in Franklin County, Dr. McKeon, in the Crisis Care Center, they've served over 1,700 people in crisis since opening Labor Day of 2025. So the question is, what percentage required transfer to a hospital ER for additional medical treatment or stabilization?
Okay, I think that I'm sure that they do a really good job of that, and other centers have shown an ability, to divert a significant majority from needing further care. So I'm going to say the percentage that needed to move on, I'm going to put it at 15%.
Okay, so you've heard Dr. McKeon's 15%. I'm asking at this point to all of you in the chat box, if you would give what you feel are the proper numbers, or if you feel that you agree with Dr. McKeon. So Dr. McKeon, I'm seeing a lot of unders coming in here. Maybe one over, but majority seems to be coming back under. So let's see where we are on the next slide. The answer is 1.3%.
Wow, that is really impressive.
It is indeed impressive. What it is really saying is that we're not doing a lot of transferring for additional medical treatment, which is really what the basis behind all of this is about. So again, I want to thank you both. Thank you, Chris. Thank you, Dr. McKeon, for being such willing participants and being a part of this and really educating us about what next steps need to be taken. So thank you both.
Thank you, Brian.
Thank you.
Thank you. And we're going to go now to our lead story for today. And it is my pleasure to bring back an old friend to provide the moderation for this debate that's coming up. Monica Johnson has over 25 years of experience in behavioral health field. Leveraging her expertise, she's also directed numerous behavioral health service areas in the government policy level, She has led the formation of several high-profile change initiatives. She's chaired a number of collaborations and served as a board member for a variety of governing boards. Before joining HMA or the Health Management Associates, she served as the first director for the 988 and Behavioral Health Crisis Coordinating Office at SAMHSA and the Health and Human Services. Monica, it is so wonderful to see you again. It is great to have you on board for this. And without further ado, I'm going to turn it over to you to moderate this wonderful panel.
Hi, Brian. Thank you so much for the introduction. I'm so excited to be here today. Happy New Year to everyone. This debate is a age-old debate. It's going to be super exciting, I think, and very robust with our two debaters. We're going to talk about medical clearance and should it be required for admission to crisis facilities. As we know, these facilities have been around for some time, but with the implementation of 988 3 years ago, we have seen robust transformation happen across this country, and that includes you're seeing more and more of these community crisis stabilization programs and facilities. And I've had the pleasure of being able to travel across this country to look at all the great work that is being done as we really look at what we need to have in our crisis continuum to make sure that people are getting access to services as they should. So today's debate will feature Jonathan Thomas and Kevin Curtis. Let me take a second just to introduce them. Jonathan Thomas joined the Alcohol, Drug, and Mental Health Board of Franklin County, Ohio in 2015, and he serves as the Chief Operating Officer. Jonathan is also a lecturer in the College of Social Work at The Ohio State University with a focus on courses covering mental health and substance use disorders, as well as program evaluation. In addition to his role in overseeing strategic planning, data analysis, reporting, and information technology, Jonathan led the development of the Franklin County Crisis Care Center, which is an innovative behavioral health crisis facility designed to offer 3 distinct levels of care with an array of integrated services, which is operated by Recovery Innovations as a part of the full continuum of crisis care serving Central Ohio. We also have Kevin Curtis. Kevin Curtis is a licensed clinical social worker and has worked in the mental health field for 19 years in clinical and administrative capacities in community, emergent, and inpatient settings. He is passionate about creating efficient and human-centered access to mental health care for people in crisis. Kevin led the development and is the operational administrator of the Huntsman Mental Health Institute, Kim and Caroline Gardner Crisis Care Center, and a new facility that provides a continuum of care for individuals experiencing mental health crisis. So we have 2 clear experts ready to discuss this very engaging topic. So I'm going to kick us off first to Kevin. Kevin is going to talk to us about why he thinks that medical clearance should be a part of this.
Thank you, Monica, and thank you for having me. It's a great honor to be with you all today. I have to out myself as a traditionalist believer that medical clearances are necessary to do crisis care in a safe way. While I can acknowledge that there are benefits to non-medical clearance systems, the reality is that that in most communities that can be a challenging thing to do. My pro-clearance argument is really foundationally grounded in the reality that most communities don't operate in a context where non-clearance systems are feasible. So, you know, like Rachel, you know, we walk around the world thinking that it works one way, and sometimes we understand due to circumstances that, oh, the rules are very different. And in most communities, the clinical realities of doing this work, operational limits that kind of dictate how we do this work, and then regulatory challenges, they often come together to create major ethics and liability concerns about doing this type of work without some prior medical clearance. So I'll talk you through each of those different pieces as part of my argument. Next slide, please. So my first point is that clinical complexity requires more advanced diagnostics to determine who can be safe in a crisis facility. This is beyond the capability of most. Behavioral presentations, as we know, routinely hide serious medical problems, and only emergency departments have the diagnostics, the staffing to reliably catch these conditions, things like hypoxia, sepsis, urinary tract infections, and other serious medical conditions that are masked by psychiatric symptoms, or the psychiatric symptoms are directly related to those underlying unmet medical needs. In addition, so many of people coming in crisis are coming with co-occurring substance use disorder that drives the crisis. Many of those common drugs of abuse, such as benzodiazepines and alcohol, they can be, withdrawal from those substances can be fatal. Most facilities lack the diagnostic testing and their consistent staffing expertise to appropriately identify those at risk of medical deterioration or in the worst cases, potential death. If something's missed, there can be bad outcomes. And what is our risk to ongoing operations and our liability for treating conditions that we may not be qualified to care for? Ultimately, medical clearance allows us to ensure that all people get the best care for their situation and that those that are appropriate can get it in a crisis center setting. My second point, operational limits really drive whether a community can do this without clearance versus needing clearance. Many crisis centers lack 24/7 staffing coverage of physicians, nurses, advanced diagnostics, or appropriate staff trained to manage the complex medical instability. And in large part, that is really dictated by payment models. In many cases, the payment models are entirely inadequate to do this at the scale that would allow it to be done without medical clearance. These programs are not resourced enough to robustly staff, to have lab capabilities, or to manage some of the medical complexity that comes in. There is, I know this might be surprising, there's actually a model that is staffed with the right people and the right diagnostic capabilities to detect and treat medical complications. It's called an emergency department. And that's why the traditional model has foundationally relied on that as part of the process, because they are capable of doing these types of screenings. In addition, with the rate of people going to crisis centers needing admit kind of hovering anywhere between 15 to 30% post the crisis stabilization, many facilities require medical clearance before you can place them into a higher level of care. Some of the managed care payers in our environment are requiring medical clearance prior to authorizing inpatient care. So there are just a host of these operational things that really drive us towards it's just safer, more sustainable to manage these operational concerns via the mechanism of medical clearance prior to crisis care. Next slide, please. Finally, pre-admission medical screening is helpful in meeting regulatory requirements for operating these facilities. Many communities don't have established receiving center or crisis center licensure designations, and they have to leverage bedded outpatient or residential licensure mechanisms that dictate what services can be provided in-house. Facilities that are systems of care, like hospital systems, those systems have systemic needs or accreditation requirements or flow through within the larger system that may dictate that pre-screening is necessary or functionally required for it to operate as a system of care. And ultimately, staff and administrators feel more comfortable in their environment when they work well within the regulatory guidelines, rather than feeling too close to areas where they're doing care provision for things that traditionally and historically have happened in emergency rooms. So there's just a lot of that drives why this may make sense. Ultimately, regulatory compliance is a thorny issue. It's easier and it's less risky to stay well within established historical precedent of doing medical screenings prior to crisis care. It's the ultimate, if it ain't broke, don't fix it. So just to summarize my position, medical screenings prior to admission, it's practical, it's safe, it protects you as an organization from risk, and it's feasible to implement in most communities. So for these reasons, I support the proposition that medical screening should be required prior to accessing stabilization in crisis stabilization facilities.
Thank you, Kevin. I think you made some excellent points, very solid, rational thinking, and I think that it represents a perspective that is shared by many. So thank you for that. So let's hear the opposite perspective. Jonathan?
Thank you, Monica. And thank you, everyone, for allowing me to take this position today. So, other than the fact I was asked to, the reason I'm debating against medical clearance prior to individuals presenting at crisis centers can be, in my opinion, best supported by 3 points I will elaborate on. So, the first slide gets into my first point. Is that medical clearance, as discussed earlier in the jam today, is not a safeguard, it's a barrier to essential healthcare. Behavioral health crises are time sensitive, and when someone is ready to seek help, the system must respond promptly. However, requiring medical clearance introduces an additional step, often hours or even longer, during an already fragile moment. So, this leads to people waiting in crowded emergency departments, potentially experiencing worsening agitation, or even leaving without receiving any care at all. So, this requirement is affecting the very individuals the crisis systems are designed to serve. Families find it challenging to navigate the confusing rules in a confusing system. EMS and law enforcement will often end up defaulting to emergency departments because it appears safer and simpler. Consequently, individuals in crisis experience the delays that escalate their risk rather than mitigate it. So it's important to note that emergency departments are not purpose built to provide behavioral health care, whereas crisis centers are. EDs can be overstimulating, noisy, and resource constrained. Sending individuals to the emergency department first does not enhance the safety of a crisis. As I mentioned earlier, it can actually worsen the situation. The next slide, and my second point that I want to raise, is further illuminating how a policy meant to protect people can actually end up doing the opposite and entrenching harmful misconceptions. At its core, the medical clearance requirement stems from an outdated assumption that behavioral health and physical health can be separated. People don't arrive in crisis with just psychiatric needs. Their brains are integral to their bodies and their symptoms, medications, conditions, social stressors, all of it's interconnected. So when we demand ED clearance, we're not enhancing care, we're shifting responsibility. We ask hospitals to act as gatekeepers because we haven't fully trusted the behavioral health system to serve as entry points. This approach perpetuates fragmentation or the silos that we're all familiar with. It teaches referral sources that crisis centers are secondary, not central. This results in many of us remaining trapped in a model where behavioral health access is filtered through systems that were never designed for it, resulting in a maze of confusion and inefficiencies. So then my third slide and my final point in my argument, hopefully, will guide us all towards solutions so we don't attempt to fix fragmentation and silos by adding more handoffs, and we instead fix it by integrating care. Across the nation, crisis centers are undergoing a transformation. They're no longer limited to single function programs. Instead, many have evolved into multi-level systems of care. Many modern crisis centers are being, or should be, equipped to provide on-site medical screening, co-located physical healthcare, and clear clinical protocols. This comprehensive approach enables individuals to receive both behavioral and physical care simultaneously, facilitated by teams specifically trained for crisis response. One significant improvement in this approach is the removal of mandatory medical clearance. Streamlines access to care, reduces unnecessary emergency department utilization, and instills confidence in referral partners that crisis centers are an appropriate initial point of contact rather than a last resort. The primary question, I believe, that arises is not whether or not medical needs should be addressed, but rather where they can be effectively, humanely, and efficiently addressed. For many individuals facing behavioral health crises, the answer is a crisis center, not an emergency department. I hope these 3 points help illustrate that requiring medical clearance before accessing crisis care doesn't enhance our system safety. Instead, it slows down the process, creates fragmentation, and diminishes its responsiveness to human needs. To establish effective crisis systems, we need to cease routing individuals through barriers and instead establish entry points that align with the actual flow of care. Well-designed crisis centers are poised to serve as the primary gateway, and it's imperative that our policies evolve to reflect and allow for this reality where more individuals have equitable access to quality community-based care. Thank you.
Well, okay, Jonathan. All right, you didn't come to play. I had a couple of questions for you all to keep this conversation going for a few minutes. Jonathan, you can maybe pick this one up, and then Kevin, if you want to respond. How confident are community crisis centers, in your opinion, in identifying medical issues without an ER evaluation? Go ahead, Jonathan.
Okay. So a lot of it comes down to the staffing. So if you intend to design the program correctly and you staff it correctly, then they're more than adequately capable of doing so. I like to say it's kind of that field of dreams type engagement. If you want to have the same system, then keep building and designing for what you have. If you want a different system, build it and design it different, and it'll come and it'll work. So if you plan for a better way, you'll have better care. If you stick to business as usual, then you're going to have the same outcomes you have now.
Yeah, I would just say I don't necessarily disagree with Jonathan. I just live in the real world where the constraints dictate what's possible, and within a real world context, I think you know it's really hard to do that with a high degree of certainty if you don't have the resource that allows you to have the appropriate staffing and diagnostics to do that work.
Okay. All right. Who should bear responsibility if a medical issue is missed? The referring clinician, the crisis center, the hospital? Thoughts?
I mean, is this not the hot potato issue that drives these decision-making processes, right? There's ultimately high risk associated with the work that happens in these spaces. And so, you know, conservative gent that I am, I just think that it's better to take the safe route.
Jonathan, any
And
thoughts on that one?
I would never argue against safety, but I also believe that all of our medical practitioners and clinicians receive training, and we have referral pathways for elevating individuals to higher levels of care. There are very few places that are a one-stop shop, fits all, can serve everything. And so it's having those clear clinical protocols that allow you to say yes more than you say no, and then be able to link people when necessary. But it shouldn't stop you from redirecting 100% of your cases for the few that might actually need to be escalated in an emergency.
All right, thank you. One more. From the perspective of a person that is experiencing a crisis, does medical clearance feel like a protection or a barrier? Thoughts on that?
I will happily go first here. From the individual receiving care, anytime you're moving them to something other than the exact services they need for why they presented, I believe all of us would believe is seen as a barrier or an unnecessary step. It's a delay in getting my needs met.
Thank you, Jonathan.
I would certainly agree that we get lots of feedback about when people have to go to the emergency room instead of coming straight to us. Uh, we also suspect that we would get feedback if they came to us and had a really bad outcome. So, you know, it's really about level setting around risk management.
Okay, thank you. All right, so I'm gonna give you each 1 to 2 minutes to make your closing statement. And I will just say for the audience, they didn't know what those questions were gonna be. So these are real experts. They took those questions and answered them on the spot. So I will start with you, Kevin, 1 to 2 minutes for your closing statement.
Yeah, I'll be real quick about it. I think Jonathan did a great job of speaking to the benefits of the non-medical screening process. I aspire to a world where direct access to crisis centers is the norm. In our current real world, these clinical realities, operational limits, and regulatory challenges, they just make this non-clearance system infeasible in most communities. Until the world changes, it's going to be difficult for this to be the model everywhere.
Thank you, Kevin. Very well stated. Jonathan?
And my closing will be brief as well in saying that I believe that all of us on this call, that regardless of the organizations that we're with or however you're watching this, our intentions and our roles, our responsibilities, our mandates are to do what's best for the individuals in need in our communities. And so I look at the resources that are entrusted to my organization, and it is to build a better way forward, and not continue to double down on the practices that we've had in communities far too long that have created inefficiencies where some of the most vulnerable residents that we all serve fall through the cracks.
Well, I would like to thank you both. This is a very complex topic. It's not necessarily black and white. You can't see the chat, I can, and the chat reflects that. So I just appreciate both of your perspectives. Thank you very much.
And Monica, I definitely want to thank you for moderating this panel. It's very intriguing. There are lots of great comments in the chat box. And I'm sure that this topic is going to be one that's talked about quite a bit longer. But thank you for being such an expert. Thank you, Jonathan. Thank you, Kevin. Maybe calling on you guys in a little bit, so don't leave us out, okay? But thank you all for this presentation. And we're going to move ahead now to our roundtable discussion. And in our roundtable today, we have Heather Honecker and Dr. Margie Balfour. And we're going to ask for some brief comments from both of you on this past presentation. So Heather, since I see you first on the screen, we'll have you go first.
Hi there. Thanks so much for having me. Yeah, just in alignment with Jonathan's position, removing that requirement to have medical clearance really does improve access, preserves hospital capacity, and supports care in the least restrictive environment. And we can train our staff. In addition to having medical professionals on staff, we can train our clinicians and our direct supports to identify medical needs. And we can also train them on how to say yes and how to employ a philosophy of care that considers the risk, but isn't driven by the risk in a way that we're designing our services around that. And that just ends up impacting every part of someone's care. I've grown up in the crisis residential programs and continue to dedicate my career in supporting them. And crisis residential has done this well for a number of years and really offers a philosophical approach that I think is helpful here in thinking about how to say yes and how to not have all of these barriers to accessing care.
Beautiful. Well, thank you so much, Heather. Wonderfully stated. Dr. Balfour, to you.
Yeah. So, in the beginning of this, if in the chat, just when the initial poll came up, there was this discussion of like, what does medical clearance even mean? And that's a term, and it was pointed out that people are trying to get away from because it doesn't really mean anything. The American Association for Emergency Psychiatry, which is a really cool organization because it's a mix of psychiatrists and ED docs, put out a consensus guideline that discusses that and says that we should be talking more in terms of medical stability. And I'll put the link to all of that when I'm done talking. But and stability includes both are there medical issues, but also the ability of the facility where they're going to be able to handle that. And that's why it's so important because as Kevin pointed out, there are facilities that aren't staffed or able to do this. And what we're really talking about is the high acuity emergency facilities. And that's why it was so important that under Monica's leadership, SAMHSA created definitions for these things. So we can start to say, well, yeah, these facilities need to have this capability. And then speaking from my own experience in actually operationalizing this, one really important thing that you need to do this is medical leadership. And that medical leadership includes both, whatever your protocols are, but I think just as importantly is relationship building with the other medical leadership in your system. And that's how without that, that's how you get all these constraints where it's like, well, we can't do this in my community because, all the hospitals require this and that. And, when I was that medical leader directly running our Tucson facility, we meet regularly with the ED leadership and their medical leadership and collaboratively come up with our protocols. Like a good example is like COVID. In the beginning, we were like, well, anyone who's got COVID, we'll send them to the ED. And the EDs, no, wait, like we're going to send half of those people home. So we together came up with the criteria of who we needed to send. That way there's no argument because it's both of our criteria. It's also a QI process. Another example of that is, we look at our data and, saw that we were sending what the ED thought was too many people for high blood sugar. And so they helped us refine our protocol better. And that's the kind of, I think, ongoing, leadership that you need. We also, our medical directors interface with the medical directors of the psych units to get them to start to have trust in not requiring a whole bunch of labs so that we don't have to then ask the ED for a whole bunch of labs because it's all one big system. And then just kind of finally want to close with, a lot of this was developed with law enforcement being the first responder, where the philosophy is you don't want to give law enforcement a whole bunch of criteria. But now as EMS is becoming more of a first responder because they're starting to get paid and there's starting to be regulatory things that allow them to drop off to these facilities, they actually do want guidelines. And Washington is a great example of that, where the state mandated the new crisis facilities and the EMS trauma councils to work together on protocols. And I can put a link to an example of that in the chat as well.
Well, Dr. Balfour, thank you. Heather, thank you both. Wonderful overview of this wonderful presentation, this debate here. We'll keep it open, and we thank you for that from both of you. I want to go now to the post-survey debate. And here it is on your screen. Here we invite you to read and respond so we can place it into the chat room. This is going to be kind of an active one, so we're asking you to go ahead and place your responses. I'm going to stick mine in there to make sure. Righty. And hopefully we can have population. If you would like to place it also in the chat box, please feel free to do so as well. What are your real thoughts?
So I'll jump in and go, and I'm super grateful for the opportunity to be able to share my real opinion on this rather than representing the affirmative argument. Ultimately, it's not that I don't believe in the argument that I made, because certainly my experience developing crisis centers, we had a phase where the real constraints of our community led us to go with the medical clearance system because it was the most feasible thing to do under those circumstances. But doing that work, we saw pretty quickly the limitations and how those systems became a barrier to treating the people that truly needed the care. And so, ultimately, for communities that are struggling to really kind of figure out the pathway towards no clearance systems, there are a couple of things that I think were really important to us. We really had to work with stakeholders across multiple different domains to communicate the value of no refusal, set realistic understanding of what it costs to do that work well and safely and competently, collaborate on reimbursement strategies that make it feasible, work with legislative partners to run that legislation to help do that. And then the second piece, culture shift. Every argument that I made, you will hear staff in crisis centers make those arguments about why we should do things that are less hard, why we should avoid some of the challenges that come up. And so when we were kind of going through that process of going from no refusal, medical clearance required, or medical clearance, kind of a less no refusal type system to one that truly does not require that medical clearance, we essentially brought it to staff members and we said, hey, we're going no refusal on this date. I know that's a scary thing. Talk us through what you need to be prepared to be able to do that work. And they gave us tons of great information that allowed us to really kind of build out the model, use their feedback to meet the concerns, leverage that back into the conversations about payment models and those sorts of things. The last point that I'll make, and it just reinforces an earlier point, one of the questions we asked them was just, if we change to this model, how many people do you anticipate will have to be sent on for medical clearance? And the answers from providers, from nurses, from social workers were as high as 30%. Right? They thought, 3 out of 10 people would have to be sent on for medical clearance. Our reality in that initial piloting of it was 1%, similar to what Franklin County is seeing. And since we moved it into the larger Salt Lake County Crisis Care Center, it stayed in that 1 to 2% range, even at the scale that we're working, where we're seeing, sometimes 1,000 people coming through over the course of a month. So this work can be done. Also, there is a great point made in the chat. Rural communities will have a very difficult time building these in a way that are resourced so that they can do this super competently. And that's where collaboration with medical facilities to do kind of emergency room with empath sort of capabilities can be a better way of doing this in a way that's really great. So thanks for allowing me to be the CAD and to represent the traditional argument, and also for letting me kind of speak to kind of my true beliefs here.
And thank you, Kevin. I want to quickly go and give Jonathan a moment also to respond before we move to the next section. Jonathan, your comment?
Yeah, again, similar to Kevin, thanks for allowing me to play a part today. My more true opinion, I would first state very clearly, I'm not a medical nor clinical professional. Nonetheless, even I know the importance of medical clearance and where the need comes from, right? It's a legitimate concern. It's about keeping everyone safe, ensuring clinical excellence, and providing responsible care. And we were very fortunate here in Central Ohio that when our community planned for the Franklin County Crisis Care Center, and for those of you who don't know that story, it was about a 10-year from idea to services process. And so through that, we were able to really look hard and look at all the data, understand needs, look at current case presentations throughout our health systems and our community-based network, and determine what do we want the new experience for crisis care in our community to be. We were then able to determine what the staffing would need to be, the cost of it, as Kevin alluded to several times. It is a different model, and it is more expensive, and you have to staff differently. And that's what our community wanted. So our community stood behind it, and we raised the funds to do it. So we're very fortunate here in Columbus to have a partnership between RI and Ohio State's Wexner Medical Center, so they can address a broad scope of physical ailments a client may present with. And so I would just encourage, I don't assume every community will need, even if so, ever have the exact same model. But it's really about that planning process and just making sure that you have, clear protocols, whatever your medical exclusionary criteria are. Make sure your first responder community has that information, and have those strong referral pathways out for when someone does exceed the capacity of your program. And we were grateful to have local EMS leadership and medical directors work jointly with the clinical staff in our center to develop those protocols for when someone needs to still go directly to an emergency department. It's just a very rare occurrence now here in Central Ohio. So thank you.
And again, thank you. Thank you, Kevin. Thank you both for a very, very, very good debate and your overviews. In the interest of time, we're going to move ahead to our SAMHSA report. And Dr. McKeon, if you're available, if you could give us some comments on what's happening at SAMHSA.
The video on?
Thank you. Thank you. So I am here. Actually, I am here at the SAMHSA 988 leadership team retreat with my colleagues. And so we're glad to all be here with you. Can you? Oh yeah, it looks like there we are. Up in the corner. We're not in the big screen. But what I'm going to do is because this is his last such meeting with us, I'm going to turn it over to John Palmieri, who has done such wonderful work leading the office in days prior to 988 and then being implemented nationally and then afterwards. So John?
Thank you, Richard. Thank you, Brian. It's good to see everybody. It's been a bit since we've been on this call, although Richard, of course, has continued to represent SAMHSA in the Crisis Jam. But we are here, as Richard said, engaged in a kind of deep dive strategic leadership retreat. Focused on a lot of continued efforts and activities across the crisis continuum. It's good to see all of you as well. Thank you for that comment. It was really interesting to hear the discussion about medical clearance because it really, to me, speaks to how far along we are coming with respect to crisis services. Like many people, I spent a lot of my career working in emergency departments, so medical clearance was just the thing that you talked about probably more than anything else in the emergency department. And it's really nice to see a conversation and people committed to not using it as kind of a blunt instrument, but rather having more nuanced conversations about how to deal with the many different aspects of getting people the care that they need. So for me, it just speaks to how much progress we're continuing to make. As Richard said, this sadly is kind of a transition point for me personally, and obviously for our team as well. I have been in this acting director role since Monica Johnson left in February. And I am now transitioning back to the deputy role, and happy to report that James Wright has agreed to take the acting director role here in the 988 office. I think most of you probably know James. He has been a tireless, committed, skilled leader in the 988 office, running operations, and obviously previous to that was a leader in working in BCL and in the private sector as well. And I know that he will serve the mission of 988 incredibly well as the leader in the coming year. For me, I am just incredibly appreciative of this entire group and what everyone has done and the accomplishments that we have made over the past 4 to 5 years that I've been at SAMHSA and in the 988 office. I think about that a lot in terms of where we were 4 years ago and where we are now. And we are sort of by leaps and bounds continuing to make lots and lots of progress. And that progress really is due to the efforts of everybody. It's not one individual's contributions. It's really a credit to everybody on this call and the partners around the country who are committed to making this happen. And so it's been a real privilege for me to be part of that journey with you and to take a moment to appreciate those accomplishments while, of course, recognizing that there is still a tremendous amount more work to be done. And I know that we all, myself included, will be committed to that mission and the vision to continue that work in the coming years. So thank you so much. And then I'm going to hand it off to James and the rest of the leadership team, because I think they would actually like to provide a couple of other updates as well.
Yeah, thank you, John. I think it's safe to say we would not be where we are today without your leadership at SAMHSA and all of the services that you've helped impact for 988. And so just thank you. And he's leaving us all with the best gift ever. He said, if you are ever in Italy and want a place to stay, he has that place. So plan your vacation, plan accordingly, and bring everyone.
You may, if you come quickly, if you arrive quickly, you may need to sleep on the floor. That's just because.
But no, I'm excited to continue the work in which we've been doing here at SAMHSA. We've been meeting to look through some of our strategic priorities for the year and how we can really streamline those and work. One of the areas that I want to continue building out on is just our collaborations and our partnerships, noting that we can't do it alone, and we've never been doing it alone, and we want to continue that process. Just a couple quick updates. If you have not seen, we did release the 2026 forecast for our grant programs. Our 4 main grant programs there on SAMHSA's website. You can just Google SAMHSA forecast. That includes our 988 Network Administration. That includes the 988 State and Territory Grant Program, our Crisis Center Follow-Up Grant Program, and our Tribal Response Program. So that gives anticipated dates of release, and then we'll be working through how we can get that funding out once it's formally approved. We also have a few products that are getting really close to the end. So we have a 911 988 risk and liability guidance doc that should be out by the end of the month. That we're excited to have, and we're re-releasing the national guidelines for crisis care and the model definitions and standards that should be out in the next couple weeks. Jill, if you have anything else you want to add to those, but otherwise, if you have not seen a look out for our e-blast and coming notifications from SAMHSA. Anything else from crisis? I didn't know it'll turn, so
Oh, no. Just for the 988-911, look for e-blast, announcing when that publication will be posted, and for the reposting of the national guidelines and definitions and standards, those will be in the same place you found them before. But so go to that website, but the TTAC will be sending out reminders that those are reposted for you to use. And it was a great document before, now it's even better. So we look forward to hearing your feedback on the document, and very interested in ways you think that we can make that document come alive for local providers, local state systems. What would you like from us to be able to take the ideas in that guidance and implement them in your community? So please feel free to contact us with all great ideas.
Back to you, Brian. Thanks
Yep,
very much
thank
for
you.
the time.
Again, thank you all, and thanks for the wisdom of SAMHSA. We really are sorry to see Dr. Palmieri leave us. We have only just a couple of minutes left, and I want to give Brian an opportunity, but I also want to get to AHP. So Dr. Hepburn, if you have some comments for us from Nashville.
Yeah, so thank you, Brian. And I wanted to thank the participants in the debate. I thought it was a really good debate and covered the area very well. Thank you to all those participants. Also wanted to thank SAMHSA. Congratulations to James Wright and the 988 team. Congratulations to Richard McKeon and his continued good work. We're really going to miss John Palmieri. He has done a great job with promoting 988. And as he said, it's made a big difference over the last 5 years. When you look at how much has been accomplished, it's really impressive. So thank you, John, and best wishes. Also, I wanted to just quickly say that there was an article in the Washington Post today on health stories that could define 2026. And so I think it's an opportunity for us to all think about what health stories we think could define 2026. We're in a new year. It's going to be exciting. There are a lot of things we can accomplish. What are the stories we would like to have for 2026? And with that, I'll pass back to Brian. I know that we're short on time, so thank you.
Thank you, Dr. Hepburn, so much. We're going to move to AHP, and AHP, my apologies, because we are really running short on time. I would suggest if you guys want to give a brief overview now, we can also pull you in on another episode as well.
Yeah, thank you so much, Dr. Sims. I think in the interest of time, it probably makes sense to do this segment in a future crisis jam. That would be great. But I will put it, I'm joined today by two of my colleagues, Erin Elaine and Ziamara Romero. They will join us for a future one, and we still want to focus on really qualitative analysis. You might remember in the last Workforce Corner that we did, we focused on quantitative analysis. This is really an opportunity to dig in, you know, what's the story of the people doing the work behind the data. And so we will focus on that next time. So in advance of that, be thinking about what are the things that you really struggle with in your crisis workforce. And then we'll see you next time. Thank you, Brian.
Thank you for your understanding, and we look forward to hearing a full report from AHP in the coming episode. Thank you. And now I'll turn it over to Kristen to take us out.
Thanks so much, everyone. Happy New Year. Welcome back to the Crisis Jam. We missed you. Big thanks to Kevin and Jonathan for today's debate, and to Monica for moderating. Medical clearance, as we saw, is a huge topic that never really fits neatly into a box. And I'm actually leaving this conversation with a lot to think about when it's helpful, when it can get in the way, and maybe some thoughtful ways we can make it still accessible for those in our community. Thank you, AHP, for being our headliner sponsor. We really look forward to your workforce segment, because strong crisis systems are going on strong supported teams, and we really appreciate your leadership there. So coming up next week, we are going to hear from Dr. Matt Goldman, who's going to join us to talk about Washington's levy and how that shows us how crisis systems are evolving at the state level. And then in 2 weeks, we're excited to welcome Dr. Tom Insel for a conversation on what happens after the crisis, the part of the continuum that often gets the least airtime in these kinds of conversations. Season 6, still happening, still exciting, going to be one of the most dynamic yet. We're really glad to see you all back. Thanks so much for watching. Be sure to tune in, log on, join the movement, and we will see you next week.
Thank you.